I want to thank the entire group for what a wonderful morning and afternoon. I've just enjoyed the speakers. You guys are amazing, and I'm learning just tons of stuff. So I'm a board-certified ophthalmologist. I practice neuro-ophthalmology, orbital disease, which means I take away eyes, and plastic reconstruction. And I've been part of the 3T team for just over a decade and have been really excited at our progress over the last several weeks and months. So I'm going to be describing this unique delivery platform, and I think that it will replace eye drops, and I do think it will replace many of the things we do, including the intravitreal injections, at least in certain parts of the world where eye drops are not practical, whether that be the Department of Defense for a deployed soldier or India, where people actually die of retinoblastoma at 50% fatality rate. So 3T is the two founders. Ricardo is a retinal surgeon. He got his PhD at Hopkins, and he's really the brain trust behind this concept. David is an amazing COO, very efficient and effective, and with a series of grants and a lot of hard work and a lot of grit, they've moved this forward, and we now have gone from bench to bedside. So I'm really excited to introduce you to the human data. So we're ready to disrupt. And we're late stage, we're looking for funding, we're looking for collaborators. I think this group is just amazing. I've had a number of people come up to me with ideas already of ways we could use my technology with their technology or other things, so really cool. So we believe that this is going to meet the shortcomings of current therapy. And why is it going to meet the shortcomings? Well, the slide that just was put up of all the problems that still remain. Compliance is at the very top. So compliance with drops, but compliance with showing up at the appointment. Compliance with your friend or neighbor or husband being able to take off from work to take you to that appointment. And then the compliance with knowing how to do the combination. Like this can provide combination therapy, and the patient doesn't have to worry about when do they put it in, how do they put it in. It's all done for the patient. It delivers one or more medications, whatever you want. So when people ask me, so what molecule is it? It's all molecules. It's all small molecules that we currently deliver as eye drops. It's all small molecules that we currently inject into the vitreous. It's all small molecules that we currently infuse intraarterially or intravenously. So it's cool. It's like a very wide drug platform. It's very easy to place, and I'll show you pictures of that, and it's customizable. So this is an artist's rendition of the episcleral device, and it sits right on the eye. It's placed in a subconjunctival pocket. You don't have to inject, so you can do it with topical lidocaine gel. Make a snip incision and push it back to where it's going to sit, and then plop it over. So it's basically face down with the medicine going straight through the sclera. So it's not wicked off. There's no systemic exposure. And you then can either use the glue port, which is very elegant and easy to use, or you could suture it if you preferred. It's easily removed, replaced, refilled. It's super simple and elegant. The episcleral system bathes the choroid, retina, and vitreous, but not just where the system is. Like I kind of thought, well, it's going to be in the quadrant where I surgically placed it. And that's because of the way the choriocapillaris pulls the medication all the way around and out into the vitreous. This is just an example of one of our preclinical slides. So the top slide shows a chronic retinal detachment model in a white New Zealand rabbit, and you can see that the white outer retina is preserved when we use the episcleral brimonidine. In contrast, it's completely gone in the chronic high detachment. In addition, you can see that the architecture of the retina is abnormal in the chronic retinal detachment. So you've got the glial proliferation, that green blob that you see. That's not happening in the lower slide. So this is the exciting, tiny episcleral system. You don't see it. So that's a picture of a conjunctiva overlying one of these systems. This is from a picture of a patient from Stanford. And it's easily taught. So we actually had 2 compassionate use cases placed by Brenda Galley, who's in Toronto, and she was taught over the phone. We have a little PowerPoint, taught her how to do it. She had no problem whatsoever. No special instrumentation. It's just very straightforward for ophthalmologists who do surgery a lot. This is actually our first guy. So this is a young man who had already lost one eye to his retinoblastoma. He had failed all treatments that are available for retinoblastoma, and he was about to lose his second eye. And Brenda called us and said, would you consider compassionate use? Do you think we could try it on my little guy? And I can tell you 15 months later, little guy still has his eye, and he's in remission. So it's really super exciting. So Brenda already reported her data. So she did 2 compassionate use patients, both of them one-eyed because of the cancer, both of them about to lose their only eye because of the cancer. And even if you're not a retinoblastoma specialist, you can appreciate that the slide that says day 0 has a bunch of little balls. That's the retinoblastoma and its seeds. And then at day 132, they're not there. Well, it didn't take 132 days. As a matter of fact, the retinal seeds and the small retinal tumors were completely eliminated in these 2 totally refractive retinoblastoma patients. So just think what it could do in a de novo patient. We currently have phase 1 clinical trials open at Stanford, and this is just an example of one of the patients who had refractory macular edema, had many, many days that he had to take off from work, have somebody drive him, get his injection, and he still wasn't improving. So over a course of 2 years, and when we placed the episcleral dexamethasone on, he had a nice response, as you can see from the OCT. So we have teams of KOLs and a number of locations in addition to Stanford that are preparing to move forward with the oncology, both topotecan, which is a chemotherapeutic for the retinoblastoma, and also the melphalan, which is mixed with dexamethasone. And that's because the way it was described to me is melphalan's kind of like, it blows things up. So we wanted to suppress some of the inflammatory response. And so we'll be proceeding with these phase 1 clinical trials soon. We anticipate the phase 1 clinical trials at Stanford will probably be completed in 2020, and the topotecan should also be completed in 2020. We have 6 open INDs, but we are not limited to 6 open INDs. We could have 300, 600, 6,000 open INDs, because we can take whatever molecule interests you, and we can formulate it to deliver it through the sclera using this elegant mechanism. Topotecan has orphan drug designation, and we do plan to have all the molecules go through the drug designation so they can get to market. We're focusing on the oncology to start with, and in the oncology you might say, well, why dexamethasone and celecoxib? Well, they're there to mitigate the issues that happen because these patients have had chemotherapy and radiation and other toxicities, so it's to mitigate that. The anti-inflammation, we have the celecoxib, which is an anti-VEGF, so it's super exciting. It could end up replacing the need to have injections. It could be these patients come in, have this placed on, you don't even need an OR. You could just place it in the exam chair, make a little snip, float it in, and they come back once every 2 years. It would make a lot of happy families because they won't have to take off from work. So as I said, the first molecules to market will be the chemotherapeutics, with topotecan leading. We'll be going for breakthrough status and hope to be to market at some point in 2021. Our estimated timeline is about 3 years to get all 4 molecules commercially manufactured and to market. And our burn is about 1.5 million, we're estimating, per quarter during that 3-year period. We've applied for the CPRIT grant, which is maybe you've not heard of. It's the Cancer Prevention Institute in Texas, where they try to move companies. We're a California company, from California, and move them and steal them and take them to Texas. So we're looking for matching funds for that CPRIT grant. So in summary, 3T hopes to change the way we care for eyes, not only here in the United States, but in third world countries where they really can't do the intravitreal injections or the eye drops. We're seeking collaborative funding, and I look forward to communicating with anyone who's interested, whether you're a clinician or you have an idea or your company thinks my company might help you, whatever might work. Thank you so much for this opportunity. Thanks.